अरे की वीडियो चालू झाली तुम्ही ऑफ करा.
Good evening, everybody. Welcome to this 49th comprehensive course on echocardiography. Today, we are going to have another session on prosthetic valve evaluations, how they look normally, how they look abnormally. In fact, if I'll say for the first words, they're almost like a normal valves. However, these prosthetic valves are slightest smaller in size as compared to native prosthetic valves. That's all I would like to say and start with this procedure. And I request everybody to silent their mic. That'll be great of them. And number of times, you know what happens? Like the IT people, they are very strong. They just subsequently remove somebody who's not listening to us at that moment and creates a lot of disturbance for doing this talk. I'll request Dr. Tamal, please switch off your video. Video is not good, Dr. Tamal. Please switch off your video. Well, I'm Dr. Rakesh Gupta from Jorop Institute of Echocardiography, Ultrasound and Vascular Doctor, Delhi. I'm going to deliver on this talk of prosthetic valve evaluations, normal and dysfunctional prosthetic valves. Well, that is what we always say. It is a man-made contraception implanted in the heart. This is a native mitral valve which regurgitates and is a metallic disc which is inserted at the level of mitral valve annulus level and another one at the level of aortic valve level, which is both of metallic as well as bioprosthetic also. What all we need before we start evaluation, these prosthetic valve evaluation is being done. The most important part which we need in day-to-day practice is the clinical information, symptoms, date of replacement, type and size of prosthetic valve, heart rate and a blood pressure. Then image of the valve from multiple scan planes, looking at the cardiac chamber, size and their functions, full Doppler study including pulmonary artery pressures, presence and location of any severity of regurgitations, and comparison with the baseline echo which was done soon after or maybe within 3 to 7 days of surgery to compare the relative values of a gradients as well as sizes. And that is what is more important in these prosthetic valve evaluation. And take my words, none of the patient carries these reports, and we are really handicapped at the moment to compare those reports. What is prosthetic heart valve? Is a foreign body which makes the valve inherently stenotic because the size of the annulus will make it inherently stenotic. Then it's only the degree that decides whether they are functioning normally or not. Next comes Dr. Samshul, please switch off your video. Next is the questions frequently asked about prosthetic heart valves. When it was operated, what was the notes? Immediate postoperative echo, immediate means within 7 days or at the time of discharge. Does the patient ever have a routine checkup after that? Does he carry any history of fever or breathlessness or any embolic episodes? And what is the mode of onset of his symptoms? And the most important thing is whether he's taking anticoagulants regularly or not. This is what all information we can get from a comprehensive evaluation of prosthetic valve. Clinical, imaging, other imaging.
Pressure ECG பாத்துறேன் அவர சரியா எல்லாம் சாப்பாடு இல்ல வாமுட்டு எது கொடுத்தாலும் வாமுட்டு தண்ணி நிறைய சாப்பிட்டாரா
This is Dr. Suchi Surendran and one more person from Maharashtra. Please silent your mic. It looks not good, like somebody will kick you out from this program completely. And I'll request everybody, Dr. Kuldeep Vyas, please switch off your video. So this is essential parameters in the comprehensive evaluation of prosthetic valves. Imaging of the valves, Doppler assessment, other imaging data like sizes of the LV-RV chambers, LA-RA size, any coexistent valvular diseases, estimation of PA pressures. Previous post-operative study, if you look at this, now it's in the bottom of everything, but it carries a lot of meaning in deciding whether the patient has got any involvement of prosthetic valve, which is making dysfunction. Very simple answer is, as we understand, the normal mitral flow velocity is 1.3. If it becomes 1.7 after surgery, and we happen to see this 1.7 later on, obviously we cannot decide whether this is abnormal or normal. So what are the types of prosthetic valve which are available in the market? It's a very simple word, is stented versus stentless. In stented, we have both porcine bioprosthetic and pericardial bioprosthesis. Similarly, in stentless, we have porcine bioprosthesis, pericardial bioprosthesis, aortic homograft, and pulmonary autograft is very common. Amongst the mechanical which are used in day-to-day practices, bileaflet, the most commonly used valve as on today, being marketed by many companies. Single tilting disc device, less common now, and majority of time we are not using ball and cage. It's a very heavy valve which we utilize in day-to-day practice. The commonest is bi, single is second, and third is rarely the caged mitral valve processes in this subset of populations. All these valves, they have three different structures. One is a sewing ring, then housing, and then the most important thing is a occluder. What is this occluder is? If you look at this valve very carefully, this is what is the sewing ring. This is ball and cage, star and goal. This is housing. And this is the ball, which is an occluder. So one, we have a sewing ring, that's the ring which is sewed to the annulus of aortic or mitral valve or tricuspid valve, wherever it is. Second is a housing structure which houses either a ball or a disc. Third is an occluder, is a disc. Second is single tilting disc device. This is a sewing ring. Correct? This is housing. And this is occluder. Correct? And finally, if you look at a bileaflet disc, this is a housing, sewing ring. This is the housing over here. One on this side, another on this side. And these are the two leaflets or two discs which appears to be occluders. If I go back and see these valves in echocardiography, what will the picture look like? So this is a housing which looks like a heavy. And here is a ball which is look like an occluders. Right? If it's a single tilting disc device in echocardiography, we only see one jet of this flow across this valve. And this is a sewing ring, and here is the housing. And last is the bileaflet disc, where we see where we see two leaflets being showing the reverberations, and we happen to see three jets of this particular valve. What do with these people who are not silencing their mic? Madan Singh Solanki is not silent mic. Somebody is talking on a phone right now. Shall I stop delivering a lecture right now?
Kick out, sir. Kick out.
No, what? Tell me what to do.
Remove them, sir. Can we silence ourselves? Our IT people.
We are trying to do everything, but these people, they never listen to anything. Now, look at the time when they're joining this program is 9:14, 9:15. They join the program, then they're not silent. They're talking on phones. They're talking with the patients. Why do you want to get to these classes, And believe my word, this is my last warning. After, if I start my class at 9 o'clock, I'll not let anybody inside. And from next time onward, if somebody is talking in between, take my words, the IT people will remove them immediately.
Yes,
And
sir.
next time onwards, they're out of the program completely. It takes a lot of efforts to conduct these classes. This is not a joke, Come and conduct the class at over here. I'm not talking to uneducated people. I'm talking to educated people.
The right decision, sir. We agree with you, sir.
Everybody is not like Avinash Balgir, his mic is open. There were two guys, they were talking continuously from Maharashtra. Look, another person, Muhammad Majrul Islam, is joining us 9:15. Anyway, this is my last warning. Look, I can't deliver the talks like this, It's impossible for me. So if I have to look at these valves, the three of them are like ball and cage, single tilting disc device, and double tilting disc device. Then comes biological valves. And these biological valves, their hemodynamics is much superior because there's nothing like an occluder for these biological valves. And we have many of these biological valves in the name of Hancock, BioCore, BioFlow, CryoLife, Paramount, Carpenter Edwards. Many of them are available as on today in the national and international markets. And this is everybody of you must be knowing about them. This is a new generation of biological valve. To begin with, we had a core valve, which was implanted at the TAVR procedure. Then came Edwards Sapiens. And these valves, they were majority of time used in aortic bioprosthetics. Next is, how do they fit them? Where do we fit them? We fit them at the level of annulus. So obviously, when we have an annulus, which is almost 2 centimeters square for that approximately of aortic valve, if you put in another annulus over there, the inherent size becomes 1.8 automatically. So that's how it works. So how they're different from a normal valves? They are acoustically dense because metallic. So they image differently. They're intrinsically stenotic and registered. So they know the normal values, what are they? And that is best of these values do we get when we are doing post-operative evaluation before discharge. Think of effective orifice area, not the valve area. The term is changed to effective orifice area, not to a valve area. And we have to understand the valve body mismatch. I'm not going to talk to you at the level of prosthetic mismatch. Patient prosthetic mismatch is another condition where a patient has been implanted a valve which is smaller than the effective orifice, smaller than the annulus of the patient. So what we need assessment of ring, disc motions, forward and regurgitant flow, assessing peak and mean gradients, effective orifice area by quantity equation, pressure heart time, and assess mismatch and decide normal and abnormal. It's a very sequence of doing this prosthetic valve evaluations. Whenever I deliver a talk, I always say, please record patient's imaging before discharging a patient after doing a valve replacements. To a large extent, I can say almost 80% of the people, they will not do that. Surgeon will never do it because surgeon is not concerned about what is the outcome of the results are. And fortunately, surgeon has to refer the patient to a echocardiologist. An echocardiologist, I don't know how much they are really busy, whether they can really do it or not properly. What and how to quantitate? This is like in today's era, what I'm going to talk about is 2 dimensions of transthoracic echo. But we do often use 2-dimension transesophageal and 3-dimension transesophageal also when we are in doubt for doing prosthetic valve. So my take-home message would be, when you can't look at a thing which you're looking for and you highly have a suspicion, please go ahead and do a transesophageal echo. And in this era of 2024, I'll not say 2D, I'll say always a 3-dimension echo. And if you can't make a diagnosis, still, I feel that other imaging multis are very useful. One of them is a cinefluoroscopy. What is cinefluoroscopy is? Just put a patient on a cath lab table and just start imaging on a cath lab table. And take my words, if 2 leaflet the valves, is one of them is stuck. So you'll see very clearly in a cath lab table, look, one valve is moving, one leaflet is moving, the other leaflet is almost fixed. And you get the answer immediately. Cardiac CT, for looking at what? The most important thing is thrombus versus pannus. Cardiac MRI and the nuclear imaging. And these cardiac MRI has to be something where the valve is MRI compatible. This is what we do in our lab every day whenever we do an evaluation of prosthetic valve. We first take a clinical information, date, type and size of the valve replacement, height, weight, body surface area, heart rate and blood pressure, symptoms and related clinical findings. Then imaging happens in 2 dimensions or 3 dimensions. 2 dimensions echo imaging is motion of the leaflet and occluder, calcium, other echo intensity of the valve components, valve showing ring and its integrity. Then the important thing comes is the Doppler information of the valve, like gradients across this particular valves, and other echocardiographic data. Like what we do is we look at the sizes of LV and RV and LA to assess whether this valve is anomaly or abnormal. And obviously, again, I'm repeating the same thing. Previous post-operative studies are very important, and what we say should be available at the level of everything. Look, this is what the information of prosthetic valves is. We look at a peak velocity, mean gradient, velocity time integral of prosthetic valve versus velocity time integral of LVOT, effective orifice area, and pressure half time. So these are the values which we look at these subset of populations. And most important thing is when we are done with the valve, I'll show you and try to compare you what exactly we do every time. Other echocardiographic parameter is the chamber quantification. The most important part is the chamber quantification, and any existent or left behind any illness which you can image. Surprisingly, we often see some patients, I'm not saying is wrong or somebody, like where valve has been replaced, the mitral valve, patient is left behind with severe tricuspid regurgitation. So these things has to be taken care of when we are doing a valve surgery. This is what this fluoroscopy is. Opening and closing angle can be easily decided by fluoroscopy or by cardiac CT. Now you can look at very carefully how did it look like. In this film, if you look at carefully over here, this disc is not moving, other disc is moving. Look very carefully. Here is the 2 prosthetic valve which is implanted inside. One disc is moving, one disc is not moving. So it's not needed all the times that we need an echo. And it's a very smart move when we are not really sure what exactly is happening. We can take the help of other multi-modality imaging. Let's look at a normal mitral prosthetic valve. Here is an example of a like mitral valve processes. To ask me what kind of process it is, I have absolutely no idea looking at this image. But I can say that this patient has got an associated aortic regurgitation with thickening of the aortic valve leaflet. And for this reason, possibly I'll suggest this, suspect that this patient had a mitral valve replacement done secondary to rheumatic process. Now, very clearly we can understand what this valve is. If you happen to look at this valve is, this is what the annulus of the valve is. So here is a sewing ring. Look, there's a motion of these leaflets. One over here, second over here. And you can see a reverberation on one on this side, second on this side. And if I hold this image, you can see a reverberation very clearly. Yeah. You can see this reverberation over here. You can see a second reverberation over here. Can you look at this reverberation?
Yes, sir.
This is what exactly is, and we can say with this reverberation, look, this is what is this is metallic bileaflet valves. So at this point, I should be able to understand, look, this is metallic bioprosthetic valve. And this is the most important thing is when we look at a metallic bioprosthetic valve. So our idea is very clear, like somebody who has put in this valve appears to be a quite intelligent person. Next comes, we look at a Doppler flow. If you look at very carefully, we have 3 Doppler spectrums in this patient. And let me freeze that. One is over here, second is over here, and third is in between. And the most important part of evaluation of this prosthetic valve, bileaflet prosthetic valve, is we have to align a Doppler beam not to the central one jets. We have to align this Doppler beam along with the peripheral jets. Why we say that? Because we have 3 jets. If you happen to look at the this metallic valve, if I go back to metallic valve in bileaflets, look, there'll be 3 jets which will be coming. One from here, second would be here, and third would be here. If you take the jet velocity from this point, it will be higher as compared to the peripheral orifices. So we have to align a beam according to peripheral orifice rather than central orifice. Same thing, if I have to align my beam, I'm not going to align with this in single tittling this device. I'm going to align my beam according to the bigger orifice. And how do we align that beam in this particular subject is, let's see this. Now look at this, the lateral orifice is much better than middle or the septal ones. So I'll align my beam along to the lateral orifice. This is 3 dimensions echo images. Look, there's all reverberations. Why these reverberations are there? Because the patient has got a metallic disc are present. And this same thing is seen in 3 dimensions echo. Although it's not much of a utility of a 3 dimensions echo, except for the fact when we are looking at a thrombus or a pannus. 3-chamber view. Now, this is the most important thing which you see in this particular patient. What we did a continuous wave Doppler across this prosthetic valve. Now, prosthetic valve, if it's a metallic, will give you opening and closing click. So here is the opening click and here is the closing click. Here is the opening click, here is the closing click. So this is how it will work. Opening and closing clicks. But in this patient, very interesting phenomena is happening. The opening click is there, but before than that, the flow of blood has started happening. And which is not abnormal, which is fairly normal. If the blood flow happens before the opening click, it means the valve is perfectly functioning. How do we evaluate this valve? We trace the Doppler spectrum pattern as we do it in mitral valves. What we get? Peak velocity, mean gradient, peak gradient, mean gradient, velocity time integral, and the heart rate. So that's what evaluation of the mitral valve, prosthetic valve. Now put in this equation. So this is what, like we utilize a formula in day-to-day practices. We have this formula of peak velocity, possible stenosis, significant stenosis. If the peak velocity is less than 1.9, is normal subject is, if it's between 1.9 to 2.5, which is considered as normal. What is our velocities? 1.43. Then we take a mean gradient. It should be less than 5 in a normal subject. So our mean gradient is how much? 3.9. Then we take a pressure half time. Our pressure half time over here is 100 millisecond and the pressure half time is less than 130 milliseconds. Next comes the value of velocity time integral of the prosthetic valve. So our VTI is 41.5 and then we take a velocity time integral across LVOT. The ratio should be less than 2.2. So if you look at very carefully, there's nothing wrong, nothing rocket science, nothing new what we're going to talk about in these subset of populations. What the same thing you have been doing is look at the same peak and mean gradient and velocity and time integrals are. And these values should be put in a chart, something like this, and compare whether this is possible stenosis or no. This is used for looking at the bioprosthetic mitral valve dysfunctions. And little more of values, like we talk of a E wave, we talk of a mean gradient, then velocity time integral of mitral valve. And we take few more parameters, stroke volume across oblique velocity time integral at mitral valve, then velocity time integral mitral valve versus LVOT. So few more parameters which are being taken as on today. If you want, like what exactly is the same thing, what we'll recommend. And when we use these parameters, we are able to say whether this is abnormal or abnormal. But at your level, I'll say that just remember those important things. What I said a few minutes back is metallic prosthetic valve. These are the gradients. And one more picture I'd like to say, look at VTI ratio, prosthetic valve. If it's a prosthetic valve, VTI ratio is very important. That's what exactly it said over here is, if the ratio has to be less than 2.5, we consider it 100% normal valves. So in turn to say, if it's a bioprosthetic, we use E wave, pressure half time, and a velocity time integral ratio, which gives you a really good values for abnormalities. Now look, this is the picture of a bioprosthetic mitral valve. And what this picture tells you, I'm showing you images. This is stented. This is one stent over here, the second stent over here. This is stentic bioprosthetic mitral valve in mitral valve position. And if you look at this in 3 dimensions echo, look, these are the valve leaflets which are opening and closing. And this is stents on which it is mounted, the valve leaflets are. And if you look at the hemodynamics of this bioprosthetic valve, metallic valve, the most important thing is the peak velocity and the mean gradients. Here's the peak velocity is 1.9. Look at the peak velocity is 2.21. So we talk of a possible stenosis. Then we talk of a mean gradient. Mean gradient is almost 7. So again, between 6 to 10. Then velocity time integral is 57.7. Now, this is the 2 points which has recently made a difference. Pressure half time less than 130. So look, his pressure half time is 114. So 2 parameters are talking of possible stenosis. 1 parameter is talking of possible normal. And the third parameter is velocity time integral of prosthetic metal valve versus LVOT. And that's what I was exactly saying a few minutes back. This is one sequence which is telling you, look, put an emphasis on this. Put an emphasis on this pressure half time. If it's more than 170, it's 100% abnormal with a sensitivity and specificity of more than 100%. And if the velocity time integral ratio of prosthetic valve versus LVOT is less than 2.5, it's 100% normal for a sensitivity of almost 100 to 95%. So when we look at a bioprosthetic valve, we look more in cases of a velocities, not to peak and mean gradient. We look more in cases of pressure half time and the velocity time integral ratios. And that's what has been amply said in this paper, which was published in American Society of Echochoreography in 2017. Because we were facing the same problem number of times. We said the gradients are high, but when we started looking at pressure half time and effective, this velocity time integral as prosthetic valve versus LVOT, we found to be normal. And this is not the place was when we said what to be considered as normal or abnormal. If I tell somebody you're carrying an abnormal valve, obviously somebody who's not carrying an abnormal valve hears some noise that I'm carrying an abnormal valve. It makes a lot of difference. Move on to prosthetic to aortic valve, from mitral to aortic processes. Look, this is the prosthetic valve implanted in the aortic valve positions. This is definitely metallic, but I don't know what kind of metallic valve it is because I could see a reverberation of the metallic prosthetic valve over here. Normal LV function, 4 chamber, 3 chamber, 2 chamber, very poor echo windows. Look at an LV thickness is 1.4, 1.8, 0.9 and 16. So 1.4 is considered to be on a higher side as we take 11 as a normal. Now, the most important thing is look at the prosthetic valve in toto. And what we did, we went on to do a continuous wave Doppler across this prosthetic aortic valve. What do we get? Peak velocity, mean gradient, pressure, peak gradient, mean gradient, velocity time integral, and the heart rate. And the most important thing, we get acceleration time and ejection time also, AT and ET. And when we look at this ejection time and acceleration time, then comes the true evaluations like how is my effective orifice area? And if you remember, when we're talking of the aortic stenosis, we were talking of aortic valve area. Now we talk of effective orifice area. And what is this effective orifice area? LVOT dimensions. And now the most important thing is we have an LVOT dimensions. What are LVOT dimensions? Is the size of the prosthetic valve implanted in the aortic valve positions. 23, 25, 27, whatever it is. So we have 2.3, 2.5, 2.7. And then you would take LVOT Doppler and continuous wave Doppler. Cross-section area of LVOT, that's valve dimensions into VTI of LVOT divided by VTI of the continuous wave Doppler give you effective orifice area. Nothing significant. It's the same thing as we were talking of aortic valve area. Here we talk of effective orifice area. Then acceleration time is the time taken from an onset to peak of the aortic valve jet. That is acceleration time. And that is always taken in continuous wave Doppler, not in pulse wave Dopplers. Third important thing comes as a Doppler velocity index. Very simple formula. And if you remember aortic valve, we were talking of dimensionless index. What was dimensional indexes? LVOT VTI divided by aortic valve VTI. Here we talk of LVOT velocity divided by LVOT aortic valve velocities. And putting all these parameters into same sequence of the aortic valve assessment, we look at a peak velocity, mean gradient, Doppler velocity integral, effective orifice area, contour of jet, and acceleration time. Why we look at a contour of a jet is, as you develop a valve which is significant stenosis, it becomes rounded in shape rather than sharp acceleration time with lowest possible acceleration time. As it becomes stenotic, it becomes more rounded and rounded rather than the sharp triangular pictures. Same thing if you look at the mitral valve. We have velocity, peak velocity, mean gradient. And another important thing is, we look at a Doppler velocity index. And here is, we are looking at LVOT velocity versus aortic valve velocities. We calculate effective orifice area and a contour of a jet by triangular early peaking with short acceleration time. And take my words, like this is what we did in this patient was, and this is a prosthetic aortic valve dysfunction evaluation, and the most common guidelines which is used as on today in 2024 for aortic valve leaflets is this particular one in European Association of Cardiovascular Imaging. They put a lot of emphasis on aortic valve acceleration time versus ejection time to consider whether this is normal valve or high flow state or patient prosthetic mismatch or some abnormalities. But at your level, I like to say, like, even if you diagnose a simple basic prosthetic valve evaluation by these parameters, it'll be a lot useful rather than going to these multiple algorithm directions. You can suspect, and if you can suspect, then obviously the next answer is refer to appropriate persons. This is what is another paper published in January 22. They said acceleration time, Doppler velocity index, and effective orifice area. Which of them is most useful in this particular phenomenon in bioaortic prosthetic valves? And these three parameters, acceleration time, DVI, and effective orifice area, which we talked about. Then acceleration time versus flow, and Doppler velocity index versus flow. And this is what the algorithm finally came out in bioaortic prosthetic valves. Why we talk of bioaortic prosthetic valve? Because we have more bioaortic prosthetic valve rather than prosthetic mitral valve, prosthetic aortic valve leaflet, metallic prosthetic aortic valve leaflets. So we talk of a velocity, talk of a gradients. Moderate or more AR on transthoracic echo. Look at acceleration time in a DVI. Mixed mechanisms, regurgitation, then obstruction, PPM, and high flow. And that's how we look for bioprosthetic aortic valve dysfunctions. So I'm not saying that you should remember all these kind of a thing. For you, it's just matter thing. Like you look at a peak velocity, mean gradient, Doppler velocity integral, effective orifice area. If you can calculate, is okay. Otherwise, first three parameters will give a fairly good idea what exactly is valve is normal or abnormal. But you need this table in your room of echocardiography. Tricuspid aortic valve. Look, this is a bioprosthetic tricuspid valve. The metallic prosthetic valve in a tricuspid position is very rarely implanted because this is a low profile area. Look at the LV pressure is 120, LA pressures are 10, RV pressure is 25, and RA pressure is only 5. If I happen to put a metallic valve, it may not open with these pressures at all. So we have to use, we call them as a low profile area, and we try to put in a bioprosthetic valve in this subset of populations. And the bioprosthetic valve definition and evaluations remains virtually the same as we talked in the previous, like during mitral valve. Look at the peak velocity, mean gradient, but put an emphasis on what? Pressure half time, and one more thing I told you. If anybody of can remember that mitral valve,
VTI ratio.
pressure half time and
VTI ratio.
VTI ratio.
VTI ratio. Perfect. That's really good. So look at the peak and mean velocity, but look at the pressure half time and the velocity time integral ratio. And where you will take this ratio now, VTI ratio? In mitral valve, you took at LVOT versus prosthetic valve. In right side, you will take this ratio at RVOT and pulmonic valve. Same thing, what we do is we look at the bioprosthetic values. If it's more than 1.7, the gradient is more than 6, pressure half time, and the ratio. And this is what has been available over a period of time. Now, though it does not say about that, it is starting finding a results. Then prosthetic pulmonic valve is a very rare implantation of the prosthetic pulmonic valve in normal circumstances. And if you happen to look where the maximum pulmonic valve involvement is present, is a post-congenital heart disease secondary to tetralogy of fellow replacements. And unfortunately, the patient having a severe pulmonic regurgitation, they still feel good despite having severe PRs. So finding a prosthetic pulmonic valve is very rare, but again, normally a bioprosthetic pulmonic valve is always implanted in this subset of populations. These are the normal one, which we look at. How do we look at them? Now, what are the abnormalities these prosthetic valve can develop over a period of time? They can develop thrombus, they can develop vegetation, they can develop pannus. Then tissue prosthetic degeneration, mechanical process problems like stuck disc and Dyson's. Disc stuck means the valve leaflet does not open. Dyson's means when the sewing ring gives way, the paravalvular leaks start happening. Then problem of in situ native valves and mismatch dysfunctions. Let's take one by one. Here is a patient who has got a bileaflet prosthetic mitral valve position implanted. Look what exactly has happened. There's a lot of scum which is present on one side, other disc is still open up and it's encroaching on the other disc also. This could be thrombus, this could be pannus, or we cannot differentiate this thrombus and pannus by echocardiography. We can only differentiate if it's a thrombus or a pannus by looking at the patient history. Pannus will take time to form. Thrombus will not take any time to form. Sudden oblique chronic history. Another example of abnormalities. And this is what is the most important thing you should remember in your life. We are handicapped whenever we talk of differentiating between pannus versus thrombus. Surprisingly, which comes handy is what cardiac CT. And we look at attenuation value of this thrombus versus pannus. Attenuation value of thrombus is more than 200 Hounds units versus less than 200 Hounds units. So in case of a doubt, when you can't think of thrombus or a pannus, always go ahead and get a cardiac CT done. And tell a person who's a cardiac CT. Unfortunately, majority of cardiac CT persons are radiologists. They are not cardiologists in our country. I can quote of Delhi. I hardly found anybody who's a cardiac CT who's a cardiologist. And I have many problems over time because I cannot explain the radiologist what exactly I'm looking for. So we have to tell them, look, I am looking at a difference between pannus and thrombus. And that's how it makes a difference. Another way of looking at thrombus and pannus is, pannus takes over a long time. Thrombus is immediate. And that's what is the most important thing in this subset of populations. History makes a lot of difference when you talk of a thrombus and pannus. And third abnormality which can happen in the subset of population is infection, infective. And majority of these infective people will not believe like a chronic phenomenon. Infective people will believe with sudden onset the parameters of inflammatory lesions. Let's go look at an example of these abnormal valves. Mrs. Sunita, 32 years female. She had sudden onset breathlessness for last 2 to 3 days. History of cough, cold, expectoration? No. And she had a valve replacement when she was just 24 years of age. Look at the important things in physical examination. Tachycardia, low blood pressure, raised JVP and NGR is positive, no anemia, no sinuses, no clubbing, and we have a mid-diastolic murmur. And what this mid-diastolic murmur tells you? That patient has got some stuck valve, like it's a mitral stenosis. And along with this, patient has a feature of a congestive cardiac failure. Borderline deranged, urea creatinine, TLC, DLC on the high side, ESR is high, and abnormal, borderline abnormal LFTs. Now look at this valve very carefully. What I'm looking at the valve, I'm looking at the valve in 4-chamber. We look at the two jets, one over here, second is over here. And there's a high profile velocity jets are present. Let me zoom up this picture for you. I think that'll be better seen over there. So we zoomed up this picture. Here's one flow, here's another flow. So if I'm able to see two flow, what kind of a valve it is?
Metallic by.
No,
Bileaflet.
metallic valve there. And we see a larger flow on one side and a smaller flow on the other side. But these flows they're turbulent. Normally we don't have this much of turbulence in this valve. And when we put in a continuous Doppler across this valve, look at the peak velocity 2.87. Look at the mean gradient 23 and the pressure velocity time integral 104. What does it suggest? This valve suggests classically, possibly it's a stuck valve. And when we look at this stuck valve, we go ahead and do an LVOT VTI 29 millimeter. Mitral velocity VTI was 104. And next parameter what we'll take is we take an aortic valve VTI, LVOT VTI, then pressure half time, LVOT diameter, and then again mitral valve. And finally, what is the findings we had this patient is increased peak velocity 2.87, mean gradient 24, pressure half time 140, ratio is 3.5, effective orifice area is 0.71, and raised pulmonary artery pressure of 49. Give me a second. I must have put them together. Yes, it is. So whatever we talked about, I just put this on a same side of a table. Peak velocity here is 2.87, significant stenosis. Mean gradient 22, more than 10. Velocity time integral prosthetic mitral valve versus LVOT 2.5, here is 3.5. Effective orifice area is less than 1. We have 71. And this is the only dimension which we found. This possible stenosis is 130 versus 200, and here is 170. 4 out of 5 were significantly abnormal. And most important thing is, look at the history of patient, sudden happening this particular process. And if we have a sudden onset, this particular process is obviously we start thinking of possible significant mitral valve stuck process. And now the question comes, why this patient has got this particular problem? Now look at this patient very carefully. Here is some kind of a scum which is seen on a ventricular side of this prosthetic mitral valve. We never see this kind of a panels or a thrombus on the ventricular side because majority of flow, because when the valve is opening and closing, where's the maximum impact? Impact is below the valve leaflets, not upper the leaflets. That's what is important. And this is what we saw of Panis. If you allow me, just let me zoom up this picture for you. You'll be able to see much better of Panis. Now you can see this Panis very carefully. Just a minute. Can you see this mobile echo density on the ventricular side of LV mitral valve? And this is what the leaflets are. Here is the mobile echo density. And what we did in this patient at that particular moment was we immediately thrombolized. Guidelines does not talk of thrombolysis. Guidelines talks of replacement of the valve immediately. And unfortunately, fortunately, we do not do replacement. Majority of time we do a thrombolysis. And we did the same thing in this patient, doing a thrombolysis in this patient. And following thrombolysis, patient had a release of this Panis and had right femoral artery occlusion. The valve became better, but had the prosthetic valve occlusion after that. Sorry, femoral artery occlusion after that.
Sir, is it a Panis or it is a clot, thrombus?
Honestly saying, to tell you, ventricular side thrombus we have not seen, because thrombus will take most of the time looks toward the valve leaflets and below the valves. We thought of a possibly Panis. We couldn't get a CT scan done at the time because we had hardly any time. Patient was having a low blood pressure with tachycardia. And we thrombolized the patient. And subsequently, what we took out was I cannot just say, we did not get the biopsy of the thing done. We did a femoral embolectomy, took out the obstruction from the common femoral artery bifurcation. So this is what is prosthetic mitral valve. And now the most important thing is the leak of the mitral valve leaflet. Look at this picture very carefully. Small mitral regurgitation will always be seen in all population of patients. And we have a small mitral regurgitation in this patient. This is a leak of mitral valve leaflet. But this patient has got a significant paravalvular leak. This is a paravalvular leak. As if the disc sewing ring with the annular given way.
আমাকে কি একটু 7 আপ এনে দিতে পারবো না? বোতলটা এনে দিবি। Yes. বমি বমি যাচ্ছে।
Tell me what to do with this lady. I'll stop over here today. I think they'll better. Who's this lady, by the way? Can you identify yourself, or I'll stop this presentation over here? Please identify yourself. You know, it's important today. It will be the interest of all the people. A young lady, this is most important. Please identify yourself. Or I'm going to close the presentation right now. Have guts. Will you like to identify, or we'll try to find it out from IT people? Well, anyway, let me finish up this, but I'll finish it up faster. I'm not in the mood to teach right now. Look, if you look at very carefully, here's the thread which is lying over here. Can you see this thread? And here is the paravalvular leak. This is a single large paravalvular leak in this patient. And these are the patients who will need immediate surgery. Look, this is the patient who's buying time from you. So we have to be very careful when we are looking for a leaks in these mitral regurgitations. Another one, 54 years male with a history of aortic valve replacement 6 years back. Gradually increasing breathlessness over a period of time. And when we looked at it, obviously we had an LVH and a systolic murmur in the aortic valve area. Look at the left ventricular hypertrophy. Then look at the turbulence across the aortic valve. LVOT diameter, we try to calculate, that was 21 number of prosthetic valve at the aortic valve levels. Now look at the continuous wave Doppler across the aortic valve. 4.79. If I don't have to say anything, any velocity more than 4 meters per second and a gradient of 40 millimeters of mercury is considered abnormal. And this is 4.79, mean gradient 57. Aortic valve VTI was 93.2. And the LVOT VTI is just 18.5. Acceleration time, look at it start to become little roundish, not a sharp acceleration time. They started becoming a little rounder in shape. And this is what is the final outcome of this patient is. And when we put up all these things together, LVOT diameter 21, LVOT VTI 18, aortic valve VTI 99, peak velocity 4.96, mean gradient 99, acceleration time 92, and effective orifice area is 62.62 centimeters square. This is what the table is. I've just little enclosed this table to a smaller size. So this is more than 4, definite stenosis. More than 35, 99. Less than 0.25, 0.187. Then rounded contour and acceleration time more than 100. This was almost 92. And effective orifice area was only 0.62. So this is what is the patient who has got a stuck prosthetic aortic valve leaflets. Then come prosthetic aortic regurgitations. In prosthetic aortic regurgitation, mild regurgitation is almost seen. And anytime when we see a paraprosthetic leak, that becomes significant. And we have to take up these people for surgery subsequently. Prosthetic tricuspid valve dysfunction is the same thing when we look at this prosthetic tricuspid. I don't have any one. For stenosis, when the gradients goes high, and the regurgitations, when the significant regurgitation happens from a paraprosthetic leaks. This is one patient from our own lab again. What this patient is, this was Hancock valve, bioprosthetic valve implanted at the mitral valve position. Patient had come with a severe mitral regurgitation, and everybody was diagnosis was possibly paraprosthetic leak. But this patient, if you look at carefully, this patient had a degeneration of a stud. This is one stent, this is another stud, and this third stud is gone from this patient. It has degenerated over a period of time. And here is the leaflet. Look at the leaflet which is prolapsing back into the LA. This is a transesophageal view. And patient had significant pulmonic regurgitation. Sorry, mitral regurgitation. This is Hancock valve 3, 2 second generation, 1 stud, second stud, and third stud. In this patient, this one of the stud out of these 3 had degenerated and leaving behind a leaflet which is becoming flail and giving rise to severe mitral regurgitations. In summary, that's what all we look for late complications: PPM, geometric mismatch, Dyson's, primary failure, thrombosis and thromboembolism, Panus formation, pseudoaneurysm, very rare, but it does happen, endocarditis, and hemolysis. Hemolysis is one word which you have to remember all the times, because whenever you use metallic valves, the closure of this keeps on destroying the RBCs. And these RBCs, they work like getting in a thrombus or a Panus formation. And that's why we use a definite anticoagulants. One thing I always say whenever talk of these kind of things is, look at the guidelines. Guidelines classically says that we should use aspirin along with anticoagulants. We still get many subjects of patients who are only taking anticoagulants. So remember this word, 75 milligram of aspirin along with anticoagulants is mandatory in metallic prosthetic valves. And whenever you're using a bioprosthetic valve, 75 milligram of aspirin is mandatory in subsequent uses. This is what is always left behind, is what is not to eat. And when we say what is not to eat is, I always use this particular images. Give me a second. I'll show you those images, what not to eat, what to eat. Just let me close it down. Second, I'll bring back my presentation of what to eat and what not to eat. And I always give to my patients, this is a basic printout of these things like what to eat, what not to eat. And I always tell them, just put on the valves of your kitchen so that whenever the things are cooked in your kitchen, at least those people tell you this is not to be eaten by you. So this is how we do in our circumstances, and I expect every one of you should do it the same fashion. So you can see my slides. Here is the presentation is herbs. We try to tell them not to eat these herbs. Then green leafy vegetables. Then third is especially the spring onions, salad. And fourth thing is brassica, like we call them as India as a band gobi. Then chili powder and hot spices. We try to avoid them because they interference with anticoagulants. Then most important thing will people will always forget. Look, asparagus, fennel and leeks nobody eats in India. Is okra or a bhindi, which majority people eat all the times, despite having a prosthetic valve. Then comes cucumber. It is not a green leafy vegetable because we always say green leafy vegetable. Then soya bean cooked and olive oil in the forms of olive or olive oils. Dried fruits or prunes, normally we do not recommend them and we have to tell them not to eat. And I think this is what 10 things are, which I always say my patients not to eat. And the best answer is just put on the wall of the kitchen. Look, these are the things not to be eaten. And I have aspirin along with anticoagulants. And every 3 to 4 weeks, definite PTINR, 3.5 to 4. That's what the limit is. So I'll stop my presentation and any questions you have, I'm ready to answer and happy to answer them. One by one, you can raise your hands and I'll pick up your questions. Anybody can question. Raise your hands first. This is a symbol of raising your hand. Dr. Gunjan Valsangi. Dr. Madhur Singh Solanki, please silent your mic.
Good evening, sir. Sir, actually, I understood the mechanical wall images, but I didn't got this biological wall images, how it will exactly look actually. There will be like...
Okay. I'll show you like what exactly you mean by what exactly you are trying to answer, ask us. Just give me a second. I'll show you a couple of images. Share my presentation. It's closed. Okay. I'll show you a couple of examples so that you understand what exactly the bioprosthetic valves are. Slide 81. So this is an example of a tricuspid valve bioprocesses. If you look at this bioprocesses, the only state will be seen, like housing would be seen, not the leaflets. Leaflets are like biological leaflets. They could be either porcine or bovine. So we just look at the stats of this subsector population. Now look, this is very carefully seen over here in 3 dimensions. These are the studs, 1 and 2nd over here, and look at the leaflet movements over here. And whenever you switch on the colors, you will find a laminar flow. Now look, this flow is laminar flow. This is not a obstructed flow. This is a laminar flow which is seen over here. Right?
Sir.
And best answer is you can get in 3 dimensions echo. Look, there is no reverberation behind. If it's a metallic, reverberation would be there. Only
Exactly.
studs
Yeah.
are there. And when this is stentless valves, believe my words, it becomes very difficult to identify those valves.
Exactly. Reverberations were very clear in case of mechanical. I was able to identify.
Metallic valve.
Sorry, metallic. But in this case, I was not able to differentiate. Actually, I was thinking like it was looking like similar, but those studs are exactly these. These are the studs, sir. Actually, true.
And another important is when these studs are also not there, stentless. Studs,
Okay.
valves. So if you do not have a history of a valve replacement by a biological valve which is studless, believe my word, that's the most difficult thing you can ever do. You'll
Sir,
always
even it is looking like some way, as I am a
normal,
beginner, it
native,
is looking
native
like
valve.
even thrombus also.
Here, this is you talking about thrombus, right?
Exactly, sir.
Yeah,
Yeah.
you have to have a history. That's why I said the first thing is take history from a patient, spend time with
Yes,
him. Look, I'm sure like many of you must be doing 100 echoes a day.
Not we.
I went to Bihar, like one person was doing 400 echoes a day. I said, he must be a robot. If I do 20 echoes a day, I'm drop dead by evening. 30 kills me up completely. Majority of reports are left behind. So it's like, for me, like if I have to do an echo, if I get a prosthetic valve, it'll take me almost 45 minutes to 1 hour to complete my prosthetic valve. Today I get a patient of mitral regurgitation and I recorded all measurements of that MR, like PISA, regurgitation volumes, then pulmonic venous obstruction flow, systolic truncations, dimensions, vena contracta. Everything are recorded today in that patient, and took me almost an hour to complete that patient. And like still the reports are pending because I need time to organize those reports completely. Then I'd look at the GLS, whether this patient needed surgery. His LV function was normal, but GLS was significantly low. So you have to be spending time when you're doing it. I don't say do 100 echoes, 50 echoes, 30 echoes. Do echo in your patient, but those echoes should be the perfect echoes. All right, I think I have answered your question.
Yes, sir. Thank you, sir. Thank you, sir.
Anybody else? That's all.
Good evening, sir.
Good evening. Go ahead.
How can we differentiate vegetation and thrombus? And I have a second question. In case of aortic valve prosthesis, is it necessary to do an transesophageal echo?
Let's take our first question. Vegetation versus thrombus, correct?
Yes.
Thrombus versus vegetation, the only one thing which help you in differentiating is the presence.
History.
Both of them would be sudden onset.
Okay.
Vegetation is infective, thrombus is non-infective.
Yes.
That's all the differences.
Yes, sir.
Second question is aortic valve evaluation. Do we always need a transesophageal echo? Correct? That's what you exactly wanted to ask. Really?
Do we always need a transesophageal echo or transthoracic maybe?
Why? You are very intelligent. I can tell you that. Why?
Because in aortic position, the prosthetic valve is difficult to visualize in transthoracic echo only.
Look, if you have a high gradient of suspicion, always go for a transesophageal echo. I don't say you should go every time for the transesophageal echo.
Okay, sir. Thank you,
Whenever you
sir.
feel the gradients are high, you look for infective. As you asked in the first question, if you are looking for infective endocarditis, infective valvular involvement, like those kind of a things, always go for a transesophageal echo.
Okay,
So
sir. Thank
whenever
you, sir.
you write, I say always use 2 or 3 modalities, transesophageal echo and a CT also.
Thank
Okay,
you so much.
right. Anybody else? Dr. Darshan. Dr. Darshan is sitting over here. Is he here or he is gone? Dr. Darshan? Look, that's another problem we are facing every day, People will log in and disappear. So I was trying to ask Dr. Darshan some question. If you not ask me, I'll ask you. Another one is Dr. Amit. Dr. Amit,
Yes,
are you?
sir.
Go ahead, Amit. Tell me what is the mean velocity, mean gradient for abnormal prosthetic valve and mitral position. What is the cutoff?
I don't remember, sir.
Lack of memory, recent memory happens in what age? Amit, when do we have a lack of
Yes,
recent
sir.
memory? Young age, old age, middle age?
Old age.
Did you listen the talk or not? Or you joined very late?
Yes, sir. I listened. No, I have listened since 9 o'clock.
Okay. Dr. Adnan Bashar, what is the mean?
Actually, I'm in train, so there may be some noise. It's 10 millimeter of mercury. More than 10 millimeter of mercury is significant, and in between 5 to 10 is possible.
Great. Good job done, Bashar. Dr. Amit, you have to read, man. You're just not going to get all these things done. We are coming an exam after that. Okay?
Okay, sir.
Dr. Sachi, go ahead and ask the question.
Sir, good evening, sir.
Good evening.
The question is something related to therapeutics, sir. Sir, do we need anticoagulation for bioprosthetic valves for more than a year? Is it lifelong required, or we can
No.
stop in between?
Anticoagulation, bioprosthetic valve is only for 3 months. Then only aspirin.
Okay, sir. Okay. Okay, sir. Okay.
Right?
Okay. Thank you.
Dr. Dr. Rahman, Muhammad Masudar Rahman.
Good evening, sir.
Good evening. Good evening.
Is there any difference in echocardiographic appearance between vegetation and a thrombus?
We just discussed vegetation and thrombus, they look alike. Only the present history which makes a difference. If it's a vegetation, it will be presenting with the history of fever. If it's a thrombus, will be presenting with no history of fever. But both of them will have a sudden presentations. Look at a TLC, DLC will give you a lot of answers. And if you can catch hold of a CT or you can do a transesophageal echo, they'll give you much better values.
Thank you, sir.
Dr. Qasim, Dr. Muhammad Ali Qasim.
Thank you, sir, for the lecture. Sir, I have no question, but I want to see some example of prosthetic valve dehiscence and prosthetic valve mismatch in echo, sir. I want to see, sir.
I showed you one prosthetic valve dehiscence and mitral valve position, and let me look at one issue for prosthetic valve mismatch, right? Give me a second. Thrombus, pannus, or what? Anybody?
Anus.
Venus.
Venus.
Venus, sir.
Below the wall.
Now, another pannus.
So vegetation.
That was pannus,
Thrombus.
and this is
Thrombus.
Thrombus.
thrombus. Now this is, what is this? Normal?
Vegetation.
Vegetation.
Where's the vegetation, man?
Spontaneous contrast.
Pardon?
Spontaneous echo contrast.
This is vegetation, man, over here.
Hmm.
Sorry.
Sir, if there is leaflet prolapse, sir,
Prolapse.
Prolapse.
associated.
Leaflet prolapse will happen where? LVOT or aortic valve?
Aortic valve.
So this is LVOT or aortic valve?
Aortic valve.
This is aorta.
Aortic valve.
So if it's aorta, this is vegetation. No, this is vegetation. This I showed you already. Somebody was asking me bioprosthetic valve. Look, this is a two studs, and here's a normal flow across bioprosthetic valve, but significant regurgitation.
Yes, sir.
So what is mismatch? This is what the mismatch is. Look, here is a tunnel, and here is a patient which has to be taken through this tunnel. So one is not created equal. This person is not equal to this person. So definition is valve process is too small relative to the patient body size. What does it mean by? Look, I'm about 100 kg of a weight. And when I go for assessment, my diameter is 1.8 or 1.9. So at the body surface area 1.8, 1.9, if I get a prosthetic valve of 1.8, 1.9, that will not be right. Look, the body surface area of this lady is about 1.7, and she has got this valve size 19 millimeters. But this patient has got a valve body surface area more than 2. And if we put in a size of 1.9 in this valve patient, he will have a definitely valve process mismatch. Why this problem comes? You know, why these problems comes for the first place? Because the surgeon is very apprehensive of dilating the LV size, annular size. Because if he try to expand the annular size, what exactly happens? Patient goes to complete heart blocks. And how do we look at these kind of a thing? Let's just show this images. I'm just not talking about all this. Here is a 26-7-year-old male presented with breathlessness. Severe surgical aortic valve replacement 3 years back. Body surface area 2. Regular anticoagulants in multi-INR. Still having a high BP and distal annexation grade 2, grade 3. And here's the aortic valve over here. Look at the still persistent left ventricular hypertrophy despite 4 weeks of a surgery, 4 years of a surgery, 3 years of, because LV, if you replace this LVOT obstruction, the LVOT thickness should go away completely. And look at the turbulence at the aortic valve still. LV function reasonably normal. And when we looked at the LVOT VTI, LVOT VTI is only 18. And here the aortic valve VTI is almost 66 with a peak velocity of 3.7 and a gradient of mean 27 millimeters of mercury. Diameter 2.2, LVOT VTI 17.7, 66.71. And if you look at an effective orifice area is 1 centimeter square. And index effective orifice area is 0.556. Now, this is a chart which you utilize all the times. In this chart, you look at the peak prosthetic aortic valve jet velocity with 3 meters per second, mean gradient more than 20. So we have a peak velocity more than 3 and the mean gradient of more than 20. Then measure effective orifice area by continuity equation and compare with normal effective orifice area. My effective orifice area is only 1.1 and calculate index aortic valve effective orifice area is 0.6 only. And when we use this index orifice area of 0.85, it is considering as patient prosthetic mismatch. So that's how we look at these patients for stenotic level. PP. In the same chart, if you look at index orifice area is more than 0.85, and then we look for Doppler velocity index. This is 0.3, this is 2.26, it's 0.35. And then based on this, we go to high flow state or other issues in this aortic valve replacements. So we have to have an algorithm consisting of all these 6 parameters together to say that patient has got PPM or not. And at least in my practice, whenever I have suspected PPM, in those subset of population were obese and looked at the valve. If the valve has been implanted for a size of 19 millimeter or 20, 19 or 21 is there, majority of them are lower size of a valve. Right? So this is one patient where we had a really PPM in our subject, and we try to look at this patient in this particular phenomenon. Because persistent LVH, persistent high blood pressure, persistent gradients, and when we look his body surface area versus the valve number was only 21.
Sir, who is going to advise what size of wall should be selected?
Correct. Very good question. A good surgeon will advise to himself, look, this patient needs a bigger valve. A surgeon is a very intelligent person. If a patient comes to him, he always looks at his body surface area. You know what exactly is happening today? Even the surgeons are learning echocardiography. I have one surgeon who is a MCH cardiothoracic surgery from Tirunelveli. And he's learning echo now. So it's not that. The surgeon has to evaluate that patient. Look, I'm going to replace this valve tomorrow. If my body surface area is 100, 110, my annular size is only 20, I'm going to land up with PPM tomorrow.
So PPM is
prosthetic mismatch. Patient
Okay.
prosthetic mismatch. So the surgeon has to be really, really confident enough. Look, what kind of a valve I should put in this patient.
The protocol, sir. The cardiographer has to advise it, or otherwise, if he is not.
How can I echocardiographer advise? Because I can only, like when we look, at least we work, I always suggest to my surgeon, look, you need a valve replacement, take care of his annular size, which appears to be small. That's all I can tell him.
Thank you, sir.
Right. Anybody else?
You were showing some dehiscence now of wall.
You still want to see a dehiscence? I showed you a dehiscence already.
You are sure, sir. But the leak should go from
LA to LV or LV to LA? That
From where the leak will go? To tell me. You tell me yourself.
is going in LV.
It should go to LA or LV? Mitral regurgitation jet will happen to where? LA or LV?
It should be LV, LA,
Right.
but in your video
In
it
my
was.
image, I showed reverse, right?
Okay, okay.
Okay. I just show it again. Give me a second.
Hmm.
I really appreciate you. You are really like, I'm sure like you are so concentrated that you can pick up that thing very easily. I'm really happy with your pickup. It's not that
Thank you, sir.
I'm happy that you are really listening to me rather than the people who did not know what the mitral valve peak or mean gradients. Just give me a second. I'm locating that leak again. You can see the slides now.
Yes, sir.
Look, this is the mitral valve. This is a transesophageal echo. Here is the LA. Here is the LV. Look at the reverberation in opposite direction.
Yes, sir.
So here is LA, there is LV. Here is a panel or a thrombus, which is seen over here. Here is the threads of the dehiscence. And here you see a leaflet regurgitation outside the mitral valve leaflets. This is inside the mitral valve leaflet. This is outside. So the picture is upside down because of a transesophageal echo.
Okay, okay.
Got
And what
it?
is threads? Sir, threads means it is the metallic thread, sir.
Sutures.
But how can this we can locate in the echo?
Here's, look at this mobile echo densities over here.
Yeah. Yes.
Look at the thrombus over here or
Yes.
penis over here. Can you see the thrombus penis over here?
Yes, sir. Thrombus where, sir? The threads I got now and.
This is thread.
Yes.
This is penis.
Penis, yes.
And when we looked at this leakage, when we looked at this thrombus and penis, then we started suspecting, could it be infective?
Yes.
So I'm happy, like whatever you picked up was perfect. I'm not saying no, because this is very important, you know.
Yes.
I share a very interesting story at this moment. One of my students.
Sir, excuse me, sir. Sir,
Yeah,
this T, the orientation, I am not able to understand, sir. In this
upside
picture.
down. Upside down. This is LA.
Where is LA, sir?
This is LA. This is LV. Here is a mitral valve with the reverberation down is a bileaflet disc. Here is a suture line. This is a suture line.
sir.
This is the leaf disc. And this patient had a paravalvular leak. This is a paravalvular leak which is happening in between the mitral valve and the annulus. Can you see this leak?
Oh. No, sir. 1 second, sir.
Color leak.
Okay,
this
sir.
Resistant flow.
Blue color, sir.
Yeah, blue color. This is a normal mitral valve regurgitation. Prosthetic mitral valve regurgitation.
Okay, sir. Okay,
So
sir.
this is blue color is paraprosthetic leak.
Okay, sir.
One of my student in 2010, he called me at 12 o'clock in the midnight in December, January. Boss, get up. I said, okay. He said, I've got a patient at 12 o'clock midnight. I'm doing an echocardiography and I found a severe mitral regurgitation and the patient had recently mitral valve replacement done. He's in Devariya right now, practicing a very leading practitioner out there. in UP. If somebody is closer by, they can identify him. So I said, no, you go back and see how can you have a severe mitral regurgitation in mitral replacement? It cannot be. I said, it is inside the valve or outside the valve. Very simple language that you use. Inside the valve or outside the valve. He came back in next 2 minutes time. He said, boss, it is outside the valve. And patient was grossly listening at that moment. 12 or 1 o'clock midnight, 10th December, January, very cold in this northern part of India. And he happened to be one of the physicians in that area who had his MVR done a few days back. And believe my words, we started moving that patient at 2 o'clock in the midnight with ambulance and oxygen and everything. And he could reach Lucknow by 11 o'clock in the morning. And we got the OT ready at SGA PGI and got his D2 surgery done. And touch wood, that person is alive today.
Yeah, sir.
So
Great.
my request of telling these words to you is, you could be one that savior. Even if you save one patient in your life, and that will make us remember all the times. That one, only one. Same thing, I'll quote an example. Patient had an acute anterior MI. I always tease this word. This is going to come next topics. Anterior MI, if you look, non-contracting basal anterior septum it means is a proximal LAD lesion. No thrombolysis will help. Only interventions. Same happens. One of the students called me up, boss, I've got an anterior MI, his BP is normal, his pulse is normal, but his basal anterior septum is not contracting. I said, move that patient immediately for intervention. He said, he'll take about an hour to restore that place. I said, forget about an hour. He'll die next 1 hour. So then we started moving that patient, and within next 1 hour, he reached to a multicentric hospital where the cath lab facilities were there. And by the time he reached with all the medicine in the ambulance, whatever we could do, his BP was 80/60 and his heart rate was 120 to 140. And immediately he was taken up for intervention. All LAD was full of thrombus. Despite the fact we were thrombosing the ambulance. So remember certain things which will make your, like, you'll stand apart from other people as a star in that area. So this is important to learn. That's why it's important to learn echocardiography. You can make hell of a lot of difference in clinical management. Patient presenting with breathlessness in the midnight. How can you differentiate breathlessness has come from a cardiac or respiratory? Just put a probe and you'll find it out quickly. Rest you can put your mind together.
Yes.
Correct. So this is what is more important in life is learn the best. Shamshul Kumar, go ahead. Kamar, you want to ask something?
Sir, how to select bioprosthetic valve over metallic valve, sir? Any cost difference is there, sir?
How to select prosthetic valve versus metallic valve? It's a clinical question. If I'm young, 45 years of age, 50 years of age, I always prefer to have metallic valve because it's a longer life. Metallic valves are put in normally in aortic and mitral valve position. If I'm 70 years of age, obviously I'll prefer to have a bioprosthetic valve because I'll not be needing anticoagulants after that. 2. Right side position is majority of time we are using a bioprosthetic valve because low profile valves are there. Because the gradients are not very high in that sort of populations. Third important, if you are using a bioprosthetic valve, you have to be very careful, bovine versus porcine, because you're going to hurt the religion of one or other person. That's very important in these circumstances. That's how we select. I always like to select because majority people presenting to us is at the age of 30, 45 to 50 years of age. So I always prefer a metallic valve in aortic and mitral valve position and preferably a bileaflet disc. Okay.
How much is lifespan of metallic?
Metallic valve goes almost 15 years more if you maintain them properly. Bioprosthetic valve average age is about 10 years. They start degenerating very faster. But then not the question of metallic bioprosthetic valve. Suppose a person is 70-year-old, I start using anticoagulants. The chances of having a cerebral bleed is very high as compared to younger populations. And to maintain INR in older population is as difficult as holding our delegates not to open their mics.
But 15 and 10 years is not much difference. No? The second surgery also required. So bioprosthetic, so they can avoid anticoagulant.
Still, bioprosthetic goes much longer than that. 15, I said average. If they maintain them well, still they go higher. Mean to say that bioprosthetic have a shorter life, metallic has got a longer life. The one Hancock I showed, it showed an average life of 25 years. It degenerated in 8 years' time.
Yes. And what about sir antigenicity of this bioprosthetic? They do not require any immunosuppression.
Genicity of these bioprosthetic valve, I don't have much idea about that, but certainly must be having, because they are obviously, there's something to do from outside the heart. Maybe have some amount of antigenicity. I have not looked at those points ever. Let me just look at them, then maybe I'll get back to you.
Thank you, sir.
Sir, one question from my side, sir.
Go ahead.
Sir, most of the time in the emergency.
Your name looks to be like Chinese. Xiaomi Light Northeast.
It's my mobile phone name.
So you're from China?
No, sir. I'm from Ranchi, Jharkhand, Arif.
Arif, you looks to be more of a Chinese rather than your Indian, you
know. Sir, my question is, most of the time, yesterday, one call came from surgery department that the patient is having the mitral valve replacement done a few years ago, and he was having dilated giant LA, dilated LV, ejection fraction 35%, and the patient was having a INR 3.1. And we have studied to maintain it IR 2 to 3, but his prothrombin time was raised. Should I stop the acetrom before surgery or should I continue, sir? Giant LA.
No. Your question is, patient has got MVR done. His INR is 3.5. He has got a
3.1. Yes, sir.
And a large dilated RV, LV with
LA and LV.
Poor LV systolic function. So what are you planning to do with the patient?
Patient is having femur neck fracture.
Okay. Then what are you planning? Like replace, you're going to do a surgery of the femur, right?
Yes, sir. Yes, sir.
So what do you need to
surgeon has given the call. Surgeon has given the call. His prothrombin time is raised. Should they continue the acetrom?
No. That's a different question. You have to switch over these people. You have to stop their anticoagulant and switch over the heparins. Not acting heparins.
Yes.
So rather giant LA giant dilated LV does not make any sense, because we need to look at later on. Why that particular phenomena at this present moment you switch over to heparins in that patient, maintain your INR, because in heparin majority of time it's not difficult, because heparin is in the hands, like regular heparins are within our hands. You stop heparin, the effect goes away. Correct?
Yes, sir. Yes.
Like I think always the simple word is, as you take care of a diabetes with infections and with surgery, you switch off all anti-diabetic drugs, switch them on insulin 3 times a day, regular insulins.
Yes, sir.
Same thing we do over here.
Thank you, sir.
So next time you change your name, don't present yourself with Chinese name Xiaomi 11 Lite 98.
Yes.
Baljit Kaura Shera.
Sir, I wanted to ask, sir, if you said in young patients, mechanical valves are more preferred over prosthetic valves. Sir, if there's a female of reproductive age group, does that matter, sir?
I knew Dr. Baljit is sitting over here. I should not have said these words. Baljit, is a very difficult question you asked me. A female of a reproductive age putting a bioprosthetic valve versus metallic valve is a multi-dollar question. But still, I'll prefer those young females to go for metallic valves. If they go into reproduction, only thing I'll say that I'll stop anticoagulant and switch over into heparins. Difficult pregnancy, difficult outcomes. But we have no choice looking after these subset of populations. And I'll not put them on a bioprosthetic valve because they'll degenerate much faster.
Yes. Okay. Thanks.
Anybody else?
That patient was of RV infarct, they succumbed. I don't know. In the morning round, he was not there. But we could not, our monitor was not having any recording what was happened with him. But he succumbed. Posterior wall, right, inferior wall and RV infarct. He was given fluid, but his output was also improved, but he succumbed in the morning. So is it, I want to ask whether there is a cardiac rupture is a mechanism, how much common in acute?
Cardiac rupture secondary to inferior wall MI?
Inferior or
no. Unlikely.
Unlikely.
And patient having an inferior wall MI with the
posterior and RV.
Inferior posterior wall MI, poor RV systolic function is more chances that patients succumb to because of poor perfusion and maybe bradycardia. Don't you do an intervention in these subset of populations? Janvi?
Yes, sir.
Did you do intervention in this patient?
No, sir. We were not having any cath lab.
Okay.
And patient was having a Vankeback phenomena in the morning.
But they died of rhythm disorder.
That may be like
that because RV infarction mean what? But his RV branch is also involved.
Right ventricular infarct. He was having inferior, posterior, true posterior plus hypotension, therefore RV, right ventricular.
That's what I'm saying. Suppose you have an RV infarct, then possibly sinus flow would be disturbed also, no?
Yes. But he was thrombolized, successful not, it was not probably successful, but patient was thrombolized. And
where are you based, Janvi?
Yes, sir.
Where are you based?
I am presently working in Gujarat, sir, Dahod.
Dahod.
It is a tribal region of Gujarat, underdeveloped. But they have started medical college, Zydus Medical College. Instead of civil hospital, there is a Zydus Medical College since 5 years.
Oh, medical colleges are mushrooming everywhere except for patients. Nobody else is there.
But we
it's
are
a reality of the reality of a day, you know.
Yes.
How can you have a faculty in medical colleges unless you pay them a significant amount of money, handsome, with protection from a crowd or a rowdy patients, and a good facility for the kids to study nearby? Nobody will come to these medical colleges.
That local people are there, they are working, but I am from Maharashtra, but just came since 2 months here.
Okay. So you got married and came over here, right?
I don't know. I am 8 years of age, sir. But we were in Arunachal when we are
in Arunachal for 2 years.
Okay, I'm sorry.
There was first a medical college government.
Okay.
They were not getting a professor, so I joined there for 2 years. And once it was a contractual post for 2 years.
You came in this Zydus Medical College, correct?
Yes.
Okay, I'm sorry. Sorry.
No,
just now, 1 month back.
2 months before we moved from Arunachal. It was a 2-year post for contractual.
Okay.
We registered this.
Actually, sir, I have not registered. My husband has registered.
So you have to pay the fees also.
My husband husband is pediatrician and I am physician, I am professor, but he is a SR in pediatrics and he has enrolled for the course.
So
But
you
we
are
both
1:1. One buy one, get one free.
Yes, sir.
Oh, you are very smart. Next time I'll take care of you guys.
Okay, sir. Okay. Thank you.
All right. Take care. All the best. Any other questions
Okay.
before we close the seminar today?
Okay, sir. Thank you.
Right.
Yes, you
Thank
can do it, sir. Thank you.
All right. Thank you very much. We'll stop over here and we'll meet next week. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.